side, sacral bone on back side, and front side is the pubic bone. The pelvis is broadly divided into two parts with the help of pelvic brim. The part of the pelvis which is below the pelvic brim is the true pelvis, and the part above is the false pelvis. The false pelvis has got iliac muscles here which support the gravid uterus in pregnancy. It acts as a cushion and it also directs the head into the pelvic cavity in labor. So, that is the function of the false pelvis. There are different planes of the pelvic cavity. So, this is the pelvic cavity, there are different planes. There are four imaginary planes. The first one is the plane of inlet and the second one is the plane of pelvic outlet. So, they are easy to remember, the plane of inlet, plane of outlet. Now, two more planes, imaginary planes, they are, you have to remember, one is at the level of second and third sacral vertebra and the second one is at the level of ischial spine. The plane which is at the junction of the second and third sacral vertebra is the plane of greatest pelvic dimension. So, the sacrum is well curved. So, wherever the plane where there is maximum curvature of the sacral vertebra is the plane of greatest pelvic dimension. So, what about the least pelvic dimension? If I visualize the pelvic cavity like this, the least dimension will be at the level of ischial spines. They are jetting inside the pelvic cavity. Naturally, least pelvic dimension is at the level of ischial spines. So, in short, we have learned four planes, plane of inlet, plane of greatest pelvic dimension, plane of least pelvic dimension and plane of outlet. These planes, the mid cavity, it is also described, pelvis is also described as pelvic cavity, pelvic inlet, pelvic outlet. We have learned there are two imaginary planes, plane of greatest pelvic dimension and plane of least pelvic dimension. They form the pelvic cavity. So, broadly there is inlet, there is mid plane and there is outlet. Why these three terms we are using? Because at these three levels we assess the pelvis whether it is adequate for the fetus during labor. So, the mid cavity is divided by, in the mid cavity there are two planes. This is the level of the greatest pelvic dimension and this is the level of the least pelvic dimension at the level of ischial spine. So, mid cavity includes two planes, they are greatest pelvic dimension and least pelvic dimension. Ischial spine, that is very important landmark in labor. It is also known as a zero station of the head in labor, and the curvature of the pelvic cavity is downward and forward. So, up to the level of ischial spines it goes downward and at the level of ischial spines it suddenly abruptly turns forward direction. So, that's what on the pelvic floor the internal rotation occurs. So, the cavity direction is downward and forward at the level of the ischial spines. This diagram explains the different cavity, mid pelvis and obstetric outlet. This one more terminology you have to learn. Anatomical outlet is plane of outlet, okay. Plane of cavity, this mid pelvis also we have learned, that is plane of greatest pelvic dimension, plane of least pelvic dimension. This chamber is all mid pelvis. And from the least pelvic dimension to the outlet is the obstetric outlet. The anatomical outlet is at this level, obstetric outlet is a chamber which is bounded by this least pelvic dimension on the top and the anatomical outlet at the bottom. So, this is the obstetric outlet. This compartment is very, very important from normal delivery point of view, and you must remember what is anatomical outlet, what is obstetric outlet. Anatomical outlet is a bony landmarks. Obstetric outlet is a chamber which starts from least pelvic dimension to the anatomical outlet of the pelvis. Okay. Side walls of pelvis are also important. Normally the side walls are parallel it can accommodate the head well in the pelvic cavity. And it should not be convergent. If the side walls are convergent, then it becomes a funnel type of pelvis, that is a male type of pelvis. Side wall also includes sacrosciatic notches on either side. So, these are the two sacrosciatic notches on either side, should admit at least 2 fingers, means this space is quite good. There is a spacious pelvic cavity. So, that is what we assess in pelvic assessment. So, we must know what is the normal direction of the side walls. They are parallel, and sacrosciatic notches, they admit 2 fingers. Clinical assessment of this mid pelvis is also very important. How do you know that greatest pelvic dimension is quite good or adequate? If the sacrum is well curved on pervaginal examination, means greatest pelvic dimension is dimension is good. Then least pelvic dimension, these ischial spines should be blunt. If they are jetting inside, they are sharp, they are jetting inside the pelvic cavity, it is narrow, this distance will be narrow. Hence, when ischial spines are prominent, then there is a mid pelvic contraction like an android pelvis, which is a funnel type of pelvis. What is the risk here? There is a risk of deep transverse arrest. There is arrest of labor in the transverse direction of the pelvis. So, that is a problem in labor. So, you must understand greatest pelvic dimension should be spacious, the sacrum should be well curved, least pelvic dimension, ischial spine should be blunt, and usually they are not identified on PV examination. If they are sharp, then it is a problem. Okay. So, what is the risk? The risk is of deep transverse arrest. Now, let us learn about the anatomical outlet, obstetric outlet of the pelvis. Obstetric outlet extends from least pelvic dimension up to the anatomical outlet. Okay. So, this part, this is the least pelvic dimension at the level of ischial spine, and this is the anatomical outlet. So, diamond shaped area. So, this chamber is the obstetric outlet. Now, in these cases, anterior wall of this chamber is deficient with the pubic arc, anteriorly it is deficient. Lateral wall is ischial spines, ischial bones on either side, and posterior wall whole of the coccyx. So, it is at a lower level. So, this chamber is the obstetric outlet. These are the boundaries of the obstetric outlet. Okay. What is the significance of this obstetric outlet in practice? Interspinous diameter is the narrowest part, and the smallest diameter, transverse diameter of the pelvis is the interspinous diameter. It is 10 centimeter. This is very important from the MCQ point of view. So, remember the least transverse diameter of the pelvis is the interspinous diameter. It is the landmark for the pudendal nerve block. Suppose I apply low prophylactic forceps or low forceps delivery. In these cases, I give pudendal block. So, I put the needle in between this below the ischial spine, ischial tuberosities up to the ischial spine, and at the above the ischial spine, I inject the local anesthetic drug. So, there the pudendal nerve goes around the ischial spine. So, it is a bony landmark for the ischial pudendal nerve during pudendal nerve block. Internal rotation of the head also occurs at the level of the ischial spines. When the fetal head enters into the pelvic cavity, it is in the transverse diameter or one of the oblique diameter. When it moves from this diameter towards the midline on the pelvic floor, that is internal rotation. It rotates on the pelvic floor, it does not rotate at the pelvic brim, it rotates at this level. So, that is known as internal rotation of the occiput. Which level it occurs? At the level of the levator ana, from where the levator ana are attached and pelvic floor starts. So, on the pelvic floor there is internal rotation of the occiput. So, indicates the zero station we have discussed, and deep transverse arrest occurs at this level if the distance between the two ischial spines is less than 10 centimeter. So, that is the significance of the least pelvic dimension in labor. Now, let us discuss details about the pelvic brim. Okay. The pelvic brim is a topmost portion of the true pelvis. It is bounded. Always you have to hold the pelvis in relation to your body. So, right and left you can understand easily and comment upon. This is a common question which is asked for the practical examination in obstetrics. So, keep the pelvis in relation to your body. The sacrum should be towards backside and the pubic symphysis, pubic bone should be in front. So, this is how you hold the pelvis when you are discussing about the pelvis. Now, you try to understand the pelvic brim is bounded by sacral promontory, is a ella of the sacral bones, sacroiliac joint, this is the sacroiliac joint, innominate line, iliopectineal eminence, superior ramus of the pubic bone and pubic symphysis on either side. I will repeat again, it is bounded because it is asked in the examination and I am repeating. Okay. This is sacral promontory, ella of the sacral bone, sacroiliac joint, iliopectineal eminence, superior ramus of the pubic bone and pubic symphysis, superior surface of the pubic symphysis along the, this one is the innominate line, this one is the innominate line. Okay. So, that is how we describe the boundaries of the pelvic inlet. Now, what are the diameters of this pelvic inlet? AP diameter means the one which runs from anterior to posterior side. So, this one is the AP diameter of the inlet. The next one is the oblique diameter. The one which starts from the right sacroiliac joint, this is the right sacroiliac joint of the pelvis. So, it is the right oblique. The one which starts from the left sacroiliac joint of the pelvis is a left oblique. So, that is how there are two oblique diameters and the greatest maximum greatest transverse distance of the pelvic brim is the transverse diameter. So, this one is the transverse diameter of the outlet. So, at this level there is transverse diameter, it is the largest diameter. How to remember these diameters? AP diameter is 11, this one is oblique diameter is 12 and transverse diameter is 13 centimeters, very easy to remember. All these three diameters, they are in the sequence, this one is 11, oblique is 12 and transverse is 13, very simple. Now, these three diameters cannot be measured clinically because I cannot put my hand inside and measure this diameter. There is other method to measure other diameter by which I can assess this pelvic brim or I can assess the capacity of the pelvic cavity. So, what is that? There are AP diameters, that is one is diagonal conjugate. Okay. You try to understand here, this is the AP diameter, pubic bone is at a right angle and the one which the diameter which runs obliquely is the diagonal conjugate. So, this is the AP diameter of the inlet, it is also known as true conjugate or conjugate vera, vera means upar ka. So, conjugate vera, true conjugate or AP diameter of inlet. So, this one is the AP diameter of the inlet, this one is the pubic bone, pubic symphysis, it is at right angle. Now, the one which runs diagonally opposite this 90-degree angle is the diagonal conjugate, very simple to remember. So, this diameter is the diagonal conjugate, it runs diagonally like this. So, from below the pubic surface, pubic angle from inferior surface of the pubic bone to the sacral promontory. This diameter I can measure clinically. I can do PV examination, I can put my fingers here, go below the head and try to reach the sacral promontory. If I can reach, I can mark out here and so this distance I measure clinically by PV examination, that is known as diagonal conjugate. Obstetric conjugate, I have to calculate from that and predict whether inlet is adequate or not. How do we calculate the obstetric conjugate? Obstetric point of view for the fetal head, whatever space is available from the obstetric point of view is the obstetric conjugate. Okay. Simple to remember, obstetric point of view, whatever space is available, that space is described as anterior-posterior space diameter is described as obstetric conjugate. Now, here what you will consider, inner surface of the sacral promontory in the midline and inner surface of the pubic symphysis in the midline is the obstetric conjugate. Naturally, diagonal conjugate minus 1 centimeter or 1.5 centimeter depending upon the tilt on thickness of the pubic symphysis, I will get the obstetric conjugate. So, this is how we calculate the obstetric conjugate. Now, obstetric conjugate measures approximately 10 centimeters or 10.5 centimeter. It is a contracted pelvis if the obstetric conjugate is less than 10 centimeter. True conjugate is AP distance. This is the AP diameter. There is no need to measure it clinically. Clinically, there are two important diameters, obstetric conjugate and diagonal conjugate. Okay. Now, pelvic contraction is at 3 levels, and from that point of view, I will assess the pelvis. So, I must know in my mind whenever I am assessing the pelvis, that can be possibility of pelvic contraction at 3 levels. What are they? Inlet, midplane means greatest and least pelvic dimension, and outlet. If there is mid pelvic contraction, then this distance, interspinous distance is less than 10 centimeter. And mid pelvis can also be predicted by adding the PSD and interspinous diameter, but it is not practiced routinely, so forget about it. Just remember, midplane contraction is there, its sacrum is flat, and if interspinous distance is less than 10 centimeter. Again, I have written here to calculate the diagonal conjugate. Here, what I am assessing? I am assessing the inlet. There is a specific way to assess the pelvic inlet by per vaginal examination and to assess the AP diameter of the inlet. Okay. The patient is given the dorsal position with empty bladder and per vaginal examination is done. With all aseptic precaution, gloves are put on, and you have to measure the diameter by PV examination. This is how I put my fingers here, and my middle finger is long. So, naturally, I can reach the sacral promontory with the middle finger. So, it is the distance between the tip of my middle finger and the inferior margin of the pubic bone. So, tip of the middle finger, which is the longest finger, and inferior margin of the pubic bone is marked out, and I keep measured my fingers. So, manually I can calculate just daily. If I am doing pelvic assessment, I can measure. So, this mark is of 12 centimeter and this one is 11.5 centimeter, like that. So, clinically we measure the diagonal conjugate by per vaginal examination. Diagonal conjugate we have discussed. So, what is the measurement of this diagonal conjugate? It is 12 centimeter. You just remember, this is one finger 1 upon 2, 12 centimeter. 12 centimeter. So, what is the measurement of diagonal conjugate? 12 centimeter. What is the measurement of AP diameter? 11 centimeter. What is the measurement of this obstetric conjugate? 12 centimeter minus 1 centimeter. So, it will be 11 centimeter, or least means 10.5 centimeter. If it is less than 10, okay, problem. If this one is interspinous is 10. If this is also less than 10, then there is a risk of contracted pelvis. It is a mid-plane contraction. Okay. So, depending upon the measurement of the diagonal conjugate, we predict what type of pelvic contraction is there. I told you we discussed the pelvic contraction at the level of at 3 levels. One is Bren with the midplane and outlet. So, when I measure the diagonal conjugate, what I assess? I assess the inlet. There, if diagonal conjugate is 12 centimeter, okay, inlet is adequate. Patient is for vaginal delivery. Okay. If it is 11 centimeter, 1 centimeter less than that, then it is a borderline pelvic contraction, borderline pelvis contraction, inlet contraction, or it is also known as mild degree. The best term nowadays we are using is borderline. There, treatment is trial of labor, means we observe the patient in labor. If the head enters and the cervix dilates well and there is good progress of labor, then it is a successful trial of labor. Then the pelvis is adequate. So, here what is the treatment of borderline pelvic contraction? Trial of labor. Means when diagonal conjugate is 11 centimeter, what is the plan of treatment? Trial of labor. When it is 10 or even less than that, it is a major degree of pelvic contraction or inadequate pelvis is the second term which is used. In all these cases, patient has to be taken for the elective cesarean section. Emergency cesarean section, there are a lot of problems. There can be leaking, there can be cord prolapse, there can be big caput, there can be infection like that. So, whatever operative procedures we are doing in obstetrics should be well planned. So, that it is a elective cesarean section. It should not be done in emergency. So, pelvic assessment is done 15 days before expected date of delivery and elective cesarean section is planned accordingly once the baby is full term. So, obstetric conjugate we predict, if obstetric conjugate is less than 10, we have discussed, it is a inlet contraction. This is up till now we have discussed what is the per vaginal examination and predicting the diagonal conjugate and assessing the inlet. There is abdominal method also to assess the inlet. Rather than saying inlet assessment, we use different term. We say it is a cephalopelvic disproportion. So, this is the cephalic end of the fetus which is near the pelvic brim and pelvis. So, cephalopelvic disproportion means for that size of the fetal head the pelvis is not adequate. So, there is a disproportion. So, it may not be a contracted pelvis, it may be a deflexed head where there is a larger diameter of the fetal head is entering the pelvic cavity. Well flexed head is a vertex presentation, the diameter of engagement is less. Once it is deflexed, the diameter of engagement is more and there cephalopelvic disproportion occurs. Head is floating at brim. In these cases, we assess the inlet clinically by abdominal method and that method is known as cephalopelvic disproportion. So, how do I do it? The name of the method is Muller-Kerr method. Muller-Kerr method. In these cases, there are other methods also. Suppose it is a borderline pelvic contraction we have discussed. What is the line of treatment? Trial of labor is given. There are other methods of assessing the pelvis. This question is asked for the MCQs. MRI is better than CT and CT is better than X-ray. However, radiation exposure is avoided. Radiation, gonad radiation is 885 millirads in these cases. Erect lateral view is taken. Erect lateral view like this. Both acetabula are overlapping and this is the AP view where interspinous distance can be measured. So, these are the indications for X-ray pelvimetry or radiation where radiation exposure is there. CPD, cephalopelvic disproportion, it is best assessed by pelvic examination also and abdominal examination also. There are two terms used. True CPD means there is specific bony inlet contraction and relative term is relative CPD means due to deflection of the head there is occipital posterior position or large size fetus is there, then that is relative CPD. Okay. It is an indication for cesarean section. CPD is a non-recurrent cause for cesarean section, like this baby is a large size baby, the next childbirth it may be a preterm baby, so the pelvis may be adequate for that. So, CPD is a non-recurrent cause for cesarean section. Now, let us discuss about, we have discussed the pelvic inlet, we have discussed the mid plane, there we have discussed greatest pelvic dimension, least pelvic dimension. Now, what is left? Anatomical outlet. Okay, anatomical outlet. This pelvis we have to hold in relation with your body. So, that sacrum is towards my back. Okay. So, this is how I am holding the pelvis. You make it like this. Now, it is a diamond shaped area. It is a diamond shaped area bounded by inferior rim of the pubic bone on either side, pubic symphysis in front, sacrotuberous ligament from sacrum to ischial tuberosity. These two are ischial tuberosities. This is ischial spine. These two are ischial spine, ischial tuberosity, anterior superior iliac spine, iliac tubercle. Okay. So, these terms you do not get confused. This is anterior superior iliac spine, this is tubercle, this is ischial tuberosity, ischial bone, and this is ischial spine. So, the ligament which starts from ischial spine ischios sacro. So, sacrum you start from here, sacrospinous ligament, sacrotuberous ligament. So, there are two ligaments. So, whenever you describe this pelvic outlet, you start from back side. So, you remember the name of the ligament also. So, here I will say sacrococcygeal joint, sacrospinous ligament, sacrotuberous ligament, ischial tuberosity, inferior ramus of the pubic bone and inferior surface of the pubic bone. So, it is a diamond shaped area bounded by these things. So, start from here, sacrococcygeal joint, sacrospinous, sacrotuberous ligament, inferior rim of the pubic bone and inferior margin of the pubic symphysis. So, that is what is pelvic outlet. It is anatomical bony outlet. I have described the anatomy. So, it is anatomical bony outlet. Okay. So, remember this term because there is obstetric outlet also. Diameters are AP diameter. This one AP diameter, this one is transverse diameter. Transverse diameter is TDO, transverse diameter of outlet. Usually in books it is TDO is written. TDO, what do you understand by TDO? Transverse diameter of outlet, and is AP diameter of the outlet. Okay. So, distance between the sacrococcygeal joint and inferior margin of the pubic symphysis is AP diameter. Transverse diameter of outlet in between the inner surface of the two ischial tuberosities. AP diameter is 13 centimeters and this one is 11 centimeters. Like that you remember. Okay. Transverse diameter is 11 centimeters in between this is what is transverse diameter. This one is transverse diameter. Broadly this is 13 centimeters or 12.5 centimeter AP diameter. So, all AP diameters of the midplane and inlet are quite spacious. There is a lot of space. There is a deficit, bony deficit also here. Transverse diameter of outlet, how can I measure it clinically? Suppose this is the pelvis, the patient is lying like this and I am doing PV examination. I remove my hand, keep my 4 knuckles here. If my 4 knuckles, I am adult, so they are admitting here, then it is adequate. It is 11 centimeters, this one. So, TDO is 4 knuckles. Clinically, we comment on the case file like this. TDO, transverse diameter of outlet, 4 knuckles. It can be measured this way also. If it is admitting 4 fingers, it is okay. If it is admitting just 3 fingers, this distance is less. But this method is applicable for subpubic angle also. Next, after TDO, what do you assess? You assess the subpubic angle of the pelvic outlet. This is the subpubic angle. Suppose I am doing PV examination, I have done the PV examination, then I will assess the TDO 4 knuckles and subpubic angle is wide, or I will say, I will make my finger like this, I will say subpubic angle wide, or I will put my 2 thumbs on either side, I will say subpubic angle is wide. But the best method to assess is this one, where if my abducted middle finger and index finger are kept here, it can be maximum abducted to this. So, it is less. If it is admitting abducted thumb and the index finger, it is good. So, this is wide, subpubic angle is wide more than 90 degree, this is subpubic angle is narrow. When the subpubic angle will be narrow? In male type of pelvis, when there is funneling of the pelvis, there is outlet contraction. So, I have to assess the subpubic angle, I have to assess the transverse diameter of outlet and I have to assess the AP diameter also. So, that is the pelvic outlet. So, this is how in a male patient and a female patient, subpubic angle is obtuse, narrow, there the subpubic angle is wide. So, here admitting just index finger and a middle finger. In the female, it is quite wide, admitting both abducted thumb and the index finger. Okay? So, that is subpubic angle is wide in female. There is one more terminology which is used, that is waist space of Morris in the pelvis. It is the space which is available for the fetal head in labor. Okay? So, when the head is born outside, if this space is normal, then there is a gap of 1 centimeter below the pubic symphysis. That gap is below the pubic angle and it protects the urethra normally. But if the subpubic angle is very, very wide, then the head may be little less below the pubic symphysis, this distance may be less. But when the subpubic angle is narrow, the head recedes back and then there is a problem. Instead of this space of 1 centimeter, head recedes back, it will be 2 centimeter when this is narrow. So, it uses the posterior space. What goes wrong here? Posteriorly there is anal canal, so there is a risk of 3rd degree perineal tear. So, this waist space of Morris is important in 2nd stage of labor. Then one more thing is the mobility of the sacrococcygeal joint, which is very important in labor. If it is mobile, then the outlet is okay, but if it is relatively fixity hampers the extension of the head in labor, and that is a problem here. So, mobility of the sacrococcygeal joint should also be assessed. In short, we will revise the different diameters of the pelvis and how to remember, I will tell you. Pelvic inlet, this is 11. This one is 12 and this one is 13. So, the greatest distance is 13. Means what? Whenever the head enters into the pelvic cavity, it will use the maximum space. So, it enters at the level of in the transverse diameter. The entry of the head is in transverse diameter, exit is through the AP diameter. Look here, the AP diameter of the inlet is 13 centimeter. So, the head has to enter in this diameter, sagittal suture in this diameter, then it has to rotate in front and it has to come below the pubic symphysis through the AP diameter. So, that is what is known as internal rotation. So, it was like this, it gets rotated towards the midline like this. So, that is internal rotation of the occiput. So, this is important. Why it occurs? Because this distance is 13 maximum and this distance is 13. So, remember here pelvic inlet 11, 12, 13, mid cavity all are 12 centimeters. The space, this mid cavity space is quite good here. Mid cavity space is quite good here. Pelvic outlet midline diameter, AP diameter is 13, oblique diameter is 12 and 11 centimeter is the transverse. So, 13 is the figure for transverse diameter of inlet and AP diameter of the outlet. Just remember this thing, you can remember the labor and you can understand the labor better way if you remember the measurement of these diameters. These measurements are asked for the practical examination. Now, what is outlet contraction? When the outlet contraction is there will be difficulty in labor. Head will get arrested at the level of the outlet. But that thing I have to assess prior only. How do you assess? By clinical pelvimetry. Means what? I assess the pelvis, I ask the patient to lie down laterally like this, I assess the TDO, Kipper scale, rural scale here and measure this distance, posterior sagittal diameter of outlet. The distance between the sacrococcygeal joint and the TDO is the PSD. So, this is posterior sagittal diameter of outlet, this I have to measure, this I have to measure. The sum of the two should be more than 15 centimeter. If it is more than 15 centimeter, then it is adequate. If it is less than that, then it is an outlet contraction. Remember, for inlet contraction, borderline pelvis, inlet contraction, there is trial of labor. But for what outlet contraction, even if it is borderline, even if it is severe, whatever it is, never trial of labor is given for outlet. Because by the time the head descends up to the pelvic outlet, the patient is already exhausted. So, there is no role of trial of labor. Patient has to bear down and she cannot bear down at the end of the second stage of the labor. That is why clinically I have to assess the pelvis prior to the onset of labor pains. That means 15 days before expected date of delivery and planned elective cesarean section. Thus, treatment for outlet contraction is always elective cesarean section. Now, very important point I have to discuss here, that is obstetric axis or birth passage. Okay. At this level, the internal rotation, this is the birth passage where the levator ani are there. On the levator ani, the levator ani starts originate from the ischial spines up to the introitus, they are pelvic floor. It is a levator ani is pelvic floor. Okay. So, what happens? Internal rotation occurs, extension of the head occurs. So, this head, if it is here like this, it gets extended and it gets borne out. It is like this and it gets borne out by the movement of extension. So, extension of the head occurs at this obstetric axis. So, what is this obstetric axis? This one is it is J-shaped axis. The direction is downward, backward here towards the sacral hollow, then horizontal, then forward. Introitus is here, anal canal is here. Naturally, it is forward, it is J-shaped. So, it is downward, backwards, horizontal and forward. This thing J-shaped axis you must remember, because in forceps application, instrumental delivery, the direction of the traction is downward, horizontal, forward. You remember like this, downward, horizontal and forward direction. In these cases, the forceps application, vacuum extraction, the direction of traction is according to the obstetric axis of the pelvis. This is how the internal rotation and extension of the head occurs on the pelvic floor, that is obstetric axis. This is the downward movement. Here the head gets rotated towards the midline, occiput rotates towards the midline. Here occiput is down here, then it rotates towards the midline in front. So, that is downward movement. Then the occiput comes below the pubic symphysis in the horizontal direction and the extension of the head. So, first vertex is borne out, then the brow and lastly the face is borne out lastly when there is extension of the head. So, this movement occurs on the obstetric axis of the pelvis. Instrumental delivery we have discussed. Different stations of the head are also identified. Little confusing, but in detail you must know. Unless you understand it, you cannot understand the forceps application or vacuum application. Remember, when the head is at the level of pelvic brim, it is -3 station, and when head is greatest pelvic dimension, it is -2 station. So, at the pelvic brim -3, greatest pelvic dimension at this level it is -2 station. You remember these 3 level points. When 1 centimeter above ischial spine the head is, it is mid cavity, or -1. 1 centimeter below is +1, 0 station is here. The head 2 centimeter below, +2 station, their outlet, it is known as outlet. When the head is on pelvic floor, +3 station, it is low forceps delivery, but it is of outlet only. Next, the head will be on perineum, means here itself, head is on perineum with the biparietal diameter stretching, maximum stretching. That thing is known as crowning of the head. The head does not recede back, and head at the introitus. This is how 5 stations are below 0 station, 5 stations are above. Like that we comment on 10 stations of the head in labor. So, remember these 2 stations only. Head at 0 station means ischial spine. 1 centimeter above is mid cavity. -1, 1 centimeter below is +1. And below at this level 2 centimeter below ischial spine we apply forceps, that is low forceps delivery, and here prophylactic forceps delivery +3 station. So, remember the station of the level of the head matters in these cases. This is how the mid cavity is +1, -1 and 0. Outlet forceps are applied at +2 station and +3 station. This is how the movement of the head occurs. This is +2 and +3 station, the head is on pelvic floor, it is not on the bony part, it is on the pelvic floor. +2 station, here the forces are applied, prophylactic forces are applied here, like that. Rotation of the head also occurs on the pelvic floor. Initially, the head is in the transverse diameter. When it enters from the pelvic cavity, the head sagittal suture is in transverse diameter, the head is in the transverse diameter. Then slowly occiput moves towards the midline and it comes in the AP diameter. So, the head may enter in the oblique diameter, head may enter the transverse diameter, but when it comes out through the outlet, it has to rotate below the pubic symphysis. This is how it should be. So, this is known as internal rotation, where it occurs on the pelvic floor. So, that is how this classification is of forceps application, high forceps, mid forceps, low forceps and outlet forceps. These two terms are asked in the examination, practical examination. Okay. What is low forceps application? When head is at +2 and even below when the head is, that is prophylactic. Prophylactic means I apply the forceps even though I know the patient is going to deliver within next 5 minutes, but I have to cut short those 5 minutes also. Within 2 minutes I want to deliver, because I want that patient should not bear down those pains, she should not have exertion. Those cases I apply the forceps. The head is +3, +2 station means low forceps. Okay. These two, this is the difference, and the rotation is complete. Complete rotation means when the head is 45 degrees short of rotation is like this. When the head is in the midline, sagittal suture is in the midline, complete rotation. So, this is 45 degrees short of rotation, this is complete rotation. Okay. Now, in these cases, accordingly we define the forceps application and pelvic axis. It is not that significant, but this terminology is confusing for MCQs. Okay. So, what is this pelvic axis? It is anatomical axis. So, there is plane of inlet, plane of greatest pelvic dimension, plane of least pelvic dimension, plane of outlet. The perpendicular drawn from the center of this pelvic inlet, if it is drawn, it crosses the umbilicus. If it is drawn behind, it crosses the coccyx. That is the axis of the pelvic cavity. It is anatomical landmark. It has no significance like that. Pelvic inclination. So, what is this pelvic inclination? Try to understand. When the lady stands, the pelvis is not like this. It is inclined like this. Means what? The anterior superior iliac spine and pubic symphysis are in one line. These are the two anterior superior iliac spine and pubic symphysis. They are in one line and the pelvis is inclined like this. Sacrum is almost horizontal with the horizontal position. So, what happens here? Pelvic inclination. This pelvic inlet makes an angle of 55 degree with the horizontal, and here it makes an angle of 15 degree with the horizontal, and this one makes a 55 degree with the horizontal. That is angle of inclination of the pelvis. This is very important thing, because if this angle of inclination changes, it is like this, had increased, then there is chance of occipito-posterior position, deflection of head and abnormal labor results. So, this is the angle of inclination of the pelvis. Okay. Increased angle of late engagement of the head also occurs with the increased angle of pelvic incline. Types of the pelvis, broadly for the practical examination you should remember, that is what I have shown in this slide. Gynecoid pelvis is the female pelvis, 50% cases. Next in order is anthropoid pelvis, 25%. These two pelvises, normal delivery occurs. In this one is contracted, male type of pelvis. Triangle pelvis, triangle inlet, 20%. Subpubic angle is very, very narrow, and platypoid pelvis means AP diameter of the inlet is narrow, it is oval. The contracted pelvis, these are the types of contracted pelvis. What was this then? It was 4 types of pelvis are identified. So, this is a Caldwell and Mahoney classification. The terminology you have to remember for MCQ point of view. Okay. Types of contracted pelvis: rachitic pelvis, osteomyelitic pelvis, Niggle's pelvis and Robert pelvis. Niggle's pelvis means one of the ala of the sacral bone is missing. So it is asymmetrical. And Robert pelvis, Robert, there are two R. This is one R and the second one. So both ala are missing, you remember like this, then it is a Robert pelvis. That is all we have discussed about the pelvis. Thank you so much.